So we're going to do maneuvers for the thoracic spine, upper, middle, and lower. And we're going to take variations in respect to that, whether they have a kyphosis or a straightening of the thoracic spine, and whether they have anterior translation or posterior translation. Most anterior translation is going to be upper, most posterior translation is going to be lower, but it's not always the case. I see anterior translations in the lower thoracic as well, so I'll show you variations around that. So I'll have you do, so his feet are flat on the floor, hands locked behind the neck. So what I'm going to do here is get really close to him. I bring my knees all the way next to his hips. And then the first thing I like to do is let him relax back so that he can be comfortable knowing that he can relax back. If they're guarding or holding any kind of tension, it's going to restrict the adjustment. So once I know he can relax, then I help bring him back forward. And I use the towel here just so I have longer arms. And it helps me be able to completely contact with him and still be able to maneuver him around any direction I want. So if I'm going to come up into the upper thoracics, the general move is I'm going to bring him back and I'm going to work my knees up higher. I'm going to bring him into a hard flexion and pull him back like this. If it's mid-thoracics, are you okay still in this posture? Okay. All I'm going to do is keep translating my knees down so that I'm either hitting high, middle, or lower. So we'll come back into that posture. This time, same thing, only I'm not going to bring him as far back and I don't have to curl him as much. So I don't have to torque the neck as much because it's mid-thoracic. So this one's going to just come straight back like this, and then lower as I fold him even further down, bring my knees down. This one he has to help me a little bit. He has to initiate a little bit because it's lower, and I have to be able to get more of a superior pull because of the disc line. If they have variations here, so for example, if he's got more kyphosis versus more straightening, if he's more kyphotic, then I'm going to address the whole thoracic spine almost the same way I'm addressing the lower thoracic. So I'm going to be engaging more of that extension and more of that axial pull or caudal pull. Cephalate pull, sorry, not caudal. Okay. Lock your hands right here. So if he's really kyphotic and I bring him forward and I want to straighten out his kyphosis, I'm going to start low and I'm going to start maneuvering him into an extension like this. And that's going to help straighten the spine. If he's straight, then I'm just going to pull him into kyphosis. So, back down right here. So if he's got a straight spine, I move him more here. And the straight spine, you treat like they're all anterior. So you're basically trying to fold him into a deep kyphosis or a deep curl. And it's more of the shoulder, the elbows pulling in like this, and I'm keeping him kyphotic all the way through. Whereas opposed to the last one, I'm pulling him more axially. If they have some type of wedging, lateral bend, or some type of rotation, then I can use the same maneuver, and because I have such control over his torso, I can effectively get the tilt and the rotation as well. So last time we treated him for right rotation or spinous left rotation with left lateral bend. So we can treat him the opposite of that this time. So we'll treat him this way. I'm gonna stay with that. So he's high here. So he already has this and this. So I'm gonna bring him here and here. and try to treat this mid-thoracic right here. So, same setup, just relax. You can do that. Exhale forward. So once I'm here and I'm fully connected and I'm at the level that I want to be and I have this control over him, I can bring him into the lateral and I can bring him into the rotation and bring him back. And that helps correct any kind of segmental rotation or lateral bend.
What I like about your technique is not always possible on somebody like me. So I would like to review. And have you ever tried a little stool, Sabrina?
No, but I have actually, I've been thinking about it.
Okay.
Yeah,
So
yeah.
So me, I'm going to show you what I do. I did a lot of judo.
Mm-hmm.
And Japanese did that on me several times in competition.
Mm-hmm.
So we have a little stool that we put, and that the advantage of that is when you're getting older, you're in a position basically that allows you to use your feet, and depending on how you want, you can be like that, put the stool away, or you can put the stool just right back in.
Mm-hmm.
And that allows you to be a bit more comfortable by
Mm-hmm.
not having a hyperflexion in your leg.
Mm-hmm.
That's one thing.
Mm-hmm.
So the stool, we're going to speak about the stool. Then I want to elaborate on the arc of tension used so forth.
Mm-hmm.
So Sabrina, here, you put the feet here, and it works absolutely great for you. Now, if we put the feet at that level, we're going to increase the tension. So some patient hypermobile, it may be interesting to have the caudal arc of tension much stiffer and allow you for a treatment on the upper part. Mm-hmm. So that's another positioning at that level. So we're talking three things. This way, like Sabrina, you have the habit to do, and putting the patient a little bit forward, excuse me, the whole body, sit a little bit forward on the table. Can you sit
Slide forward.
Slide forward. Very good. Thank you for the translation. And you put your, very good. And here we have an increased lordosis. So think we have a cover different modification of the technique. You talked about the crossing of the arm passively. That people who have seen other video knows why. Passive range of motion, we have an increase in the range of motion when we do a movement, when the movement is done for us. So we increase the tension in the mid-back. Anything else?
There's a couple other variations when there's either a rotation or a lateral bend that I could show.
So that would be great. Can you show us that?
Okay.
And I'm just stepping out of the way.
Okay. There's two other variations with this technique that involve if a patient has a scoliosis or any kind of thoracic torsion. So a good example would be, let's assume he has both. Let's assume he has a little bit of a right scoliosis with some, it would be spinous left rotation, so body right rotation. So imagine the ribs on the right-hand side are more posterior because of the rotation and because of the thoracic scoliosis. So if I'm going to take that into consideration when I'm trying to, one, create a neuromuscular education, but also cavitate the joints, I'm going to be able to use the same technique that I can maneuver his body. And because I'm so close to him, I can manipulate him easily and safely without him feeling like he's got to hold on. So it makes it a lot easier for the action to take place. So we'll go back to that same posture here with your hands behind your neck. And your neck is okay right there? Yes. So what I'm going to do is just set up in the same. I'm going to assume I'm adjusting right here mid-thoracic between T6 and T8. And I'm going to bring him forward. I'm closing his elbows a little bit because that's creating even more of that tension across. And as I bring him forward, Same setup. The only difference is as I come forward, I'm going to take his body and tilt him to the right so that it takes out that curve, and I'm going to rotate him this way, and then I'm going to come back. And it just opens up and gaps the joints out of that scoliosis and out of that thoracic torsion.
So great, I love this approach, Sabrina. So I'm going to compliment on it because we talked with the arc of tension of basically derotating the spine all the time to make it the most standard possible. So we have the tension that we're used to. It's obvious that if we're used to treat, most of our patients don't have too much scoliosis. So if we have a bigger scoliosis, we want to be familiar with the feeling that we will receive from the patient. For that, we derotate the patient. It's exactly what you do. Thank you for that great demonstration. Now, something that you may be interested in. What I do is I don't know, only one foot. So I will raise one foot on one side, and what it will create the tension on that side much more than on the other side. And obviously, depending on what level we treat, we will have a depression of the shoulder homolateral or contralateral, depending if we have Lovett positive or negative. That's for another type of things. But basically, raising the leg is also with the shoulder depression that you mentioned and the rotation may add even a little bit more to it. Thank you.
Yeah,
That was
you're
great.
welcome.